We thought we would go through some of the things that are new since the last set of guidelines. The last set of guidelines came out about 10 years ago. And there was an update in 2019 focusing on just a few hot topics at that time. But there's been a lot that has happened in the last 10 years. And in fact, if you look at the text in the 2014 guidelines, it's about 50 pages of text and figures and tables. It's more than double that now. So so a lot has happened in between. All right, so just want to introduce the first concept here that we talked about, which was this introduction of AF stages. So we sort of took this a little bit from the heart failure guidelines, but the concept here is that we still have this idea of paroxysmal, persistent, longstanding, persistent, but we introduced a couple of concepts here. One is that you don't really know how to label people who've had a successful ablation, and we thought about using the word remission and something along those lines, but in the end just decided on this sort of successful ablation stage. And then we also introduced these concepts of sort of what happens to you before you develop atrial fibrillation. Obviously, the population at large may have some risk factors, and these are just people who have risk factors for AFib in the general population. They're just at risk for AFib. But then there's a whole set of category here called pre-AFib, and that's a little bit different. That more goes along the lines of people who have very specific signs of high risk of AFib. So you get these all the time when you order the ECG patch monitors. You see people with a high burden of PACs or a high burden of these bursts of atrial tachycardia. Those people are at very high risk of having a subsequent atrial fibrillation. You're not going to see a lot of the recommendations here in the guidelines around these concepts of pre-AFib, but what we're hoping is that this will sort of open up in the research community for us to study this and to really learn whether or not things like heightened surveillance make sense in this population. So hopefully more to come in the next guidelines. I want to start with the definition of AFib. If you go back historically, very old set of guidelines, you see this 30-second rule. It just pops up. It's kind of out of nowhere. It's a bit arbitrary. There's no data sort of to back it up. But the concept used to be that if you had 30 seconds of AFib on a 24-hour Holter, that was enough to make a diagnosis of atrial fibrillation. The problem, of course, is that now we monitor people for much, much longer than 24 hours. And so 30 seconds of AFib just doesn't make sense anymore. So actually, in the last set of guidelines, the 30-second rule was removed. But in this set of guidelines, what we did want to introduce into the definition was this idea of being able to make a diagnosis using things other than a surface ECG. Wearables are a lot more commonly used now, and I often get the question, can I use this ECG from the wearable to make a diagnosis and make management decisions? And the short answer is yes. I mean, you do have to look at it. You do have to assure yourself that it's high enough quality, and if you're confident about the quality and the rhythm, then sure, you can use that in your clinical practice. Same thing with intracardiac EGMs from these devices. As long as you look at it and you agree that it looks like atrial fibrillation, then you can make a diagnosis. The other concepts that were introduced in these guidelines are this idea of AF burden. That's going to come into play as we talk about how you think about risk stratifying patients. And then there's this concept of subclinical AFib. Now, the concept's been around for a while, but there's a lot more data around this idea that there are people who have atrial fibrillation, are just asymptomatic, but for one reason or another, maybe they have an implantable device, maybe they were wearing a wearable device, they were found to have atrial fibrillation. And what do you do with them? Do you anticoagulate them or not? And so we'll address that in a second. So when we're thinking about screening for atrial fibrillation, there's been a lot of data over the last 10 years around the idea that if you screen people who are at risk for atrial fibrillation, you will find people who have atrial fibrillation. And in fact, the more you screen, the more of them that you find, and the longer you screen, the higher the chance that you will find people. And there are multiple modalities that have been looked at: spot checking multiple times, or just the ECG patch monitors, or even implantable monitors. I mean, clearly, the more you screen, the more you will find. So the question then becomes, do you start screening the general population? Do we recommend screening? I mean, if we know we can find these patients with atrial fibrillation out there who are asymptomatic, should we start screening? The US task force and ultimately the guidelines here, we decided not to make that recommendation, primarily because we just don't know yet if we screen these asymptomatic patients and find AFib, is there a benefit to anticoagulating? There's not yet a definitive answer in that realm. The Europeans have decided that in their guidelines, they were going to recommend essentially opportunistic screening. So if you see somebody in the office and they're over 65, maybe they have some risk factors, check their pulse, maybe check a strip, an ECG strip, and maybe you'll find AFib and manage it that way. All right, the exception to this is those who have had a stroke or a systemic embolus. This study came out, 10 years ago, the Crystal AF study. People who had strokes had implantable loop recorder, and very clearly there was a much higher rate of atrial fibrillation. We know that's the case with these other studies, but because there's what we thought that because they are at such a high risk of having another stroke, that it would be reasonable, without randomized controlled data to support this, but we thought it would be reasonable to recommend anticoagulation in that population. So there's now a class 2A recommendation to screen those patients who've had a stroke. And screening with an implantable loop recorder, this is more recent data, is more advantageous than screening with just, say, an ECG patch monitor. So you will, again, the more you screen, the more you will find. Just as a reminder, when we talk about these guidelines, is that we give these recommendations a class. So class is based on this risk benefit. So not so much the science behind it, but rather whether or not we overall think that the benefit does or does not outweigh the risk. So class 1 is a clear, great benefit over risk. All right. And then the level of evidence is based on the science. Are there randomized trials? Are there multiple are they good randomized trials? Do we have good meta-analyses? Or is it just based on observational data? Okay, so we're going to talk about prevention. So in the older guidelines, from 10 years ago, really the focus was on stroke risk management and symptom management. But there's a whole new section now in this set of guidelines on sort of optimizing risk factors. So if you have a patient with atrial fibrillation, many of them will have comorbid conditions, risk factors for AFib that need to be managed. So things like hypertension, diabetes, but then they also have sort of habits and other environmental exposures that should be addressed. And part of the reason this was added in this set of guidelines is that now there's a lot more data around these recommendations to support them in the guidelines. One of the big studies that came out several years ago was this randomized trial of weight loss intervention, and this is from Prash Sanders in Australia. It wasn't a very big study, but in that study they were very, very strict about diet restrictions, and it was very hands-on, and they achieved a very successful weight loss in their cohort. And they found, for the first time, that a randomized trial showed that intervening and on weight loss actually improved burden and symptoms in these patients. So that was sort of a first study of its kind. Again, not very big, but very impactful. This is a study that we refer to a lot, and in part based on that, there's now a class 1 recommendation that if you've got a patient with a BMI over 27 who has AFib, you really should recommend that they lose weight. Similarly for exercise is a little bit complicated in AFib. Very high levels of exercise, endurance training, things like that do lead to a greater degree of atrial fibrillation. But moderate exercise, at least in observational studies, a little bit of a debate on this, but that has shown some reduction in atrial fibrillation. But it wasn't until this study that we had sort of again, it was a small study, but it was a very hands-on interventional study on exercise. And those who did go through the program compared to controls had less recurrence of atrial fibrillation. So now exercise gets a class 1 recommendation. So if you have a patient with AFib, we are supposed to now recommend that they at least exercise for about 210 minutes per week. It's about half an hour a day. All right, what about some of the habits? So smoking, again, no randomized trial here, but we feel that smoking is so important that we gave it a class 1 for many reasons. There is some data saying if you smoke, retrospective data saying if you smoke less, you'll get less AFib. But despite that, the fact that there's no randomized trial, this gets a class 1. Alcohol is a little bit different. There's a little bit of a back and forth in the retrospective literature about whether or not alcohol is associated with more AFib. But this study that was done not too long ago, again, small study, about 140 patients, randomized to abstinence versus just control, did show a reduction. So if you are able to successfully get your patients off alcohol, then they will have less AFib. And that's now class 1 recommendation. All right, so for all you coffee drinkers, this is good news. So caffeine, again, back and forth in the retrospective literature, no clear answer there, but we felt that there was not enough data to support recommending that patients stop enjoying their cup of coffee every morning. All right, so we talk a lot about sleep disorders in atrial fibrillation. It's very, very clear that if you have sleep apnea or another sleep disorder, you are at higher risk of atrial fibrillation. That's very, very clear. What isn't so clear is whether or not intervening, in other words, putting these patients on CPAP actually helps reduce their atrial fibrillation. A couple of very small randomized trials looked at this question, could not conclude that it was beneficial. But there's a class 2B recommendation in patients with AFib only because it is so common. About 20% of patients with AFib also have undiagnosed sleep apnea. And so the recommendation there is more so because they may have other benefits to getting sleep studies and potentially put on CPAP. So not necessarily for AFib reduction. All right, so how are we going to do this? Because this has a lot to do in the EP clinic and in the cardiology clinic. And now there's a class 1 recommendation here that you should do it. You really should be talking to your patients about all of these risk factors. And one suggestion, of course, is to have extra help. There are nurse-led clinics, for example, where it may be beneficial to have patients with these risk factors with AFib sent. And in fact, this is a plug for Linda's clinic. So Linda Ottoboni has a clinic specifically designed to do this. So if you have a patient with atrial fibrillation and multiple risk factors, don't really have time to talk to them about diet and exercise and so forth, this is the perfect patient to refer to Linda, and she will spend the time and discuss all of these modifiable risk factors. All right, so checking in on Mark. Oh, Mark is here. Mark has joined us. All right, so Mark, it's good to see you. Can you hear us okay?
Yeah, I can. I'm looking a lot better on your slides than I am in real life.
So we used a little bit of generative AI to picture what you were doing over there in Spain. And, generative AI thinks that, you've been exercising a lot, trying to prevent AFib. So Mark, we wanted to just take a break between some of these sections to see if you could go through the chat and see if anybody's asked any questions and try to address some of them. So anything burning in the chat discussion?
Great. I'll take a look, and I am happy to serve in the role of sidekick here and just add some context from time to time. These guideline committees do this in the same kind of way as before, and they're getting very good at it. I've been on quite a few of them, and so but you're the real expert here, so I'm looking forward to hearing your summary. And this is I'm beginning to like generative AI. I don't know.
You do look quite toned in this picture. All right, so we'll jump ahead, and then we'll take another break and see if you see any burning questions there on the chat. All right, well, let's talk about stroke prophylaxis. This is a big component of the guidelines and a lot of what we end up doing. So as Mark will probably tell you, we had a really long discussion. In fact, this debate kind of extended, I think, to 2 different sessions because there was a lot of controversy here. So in the older set of guidelines, the recommendation was that everybody use CHADS-VASC. I would say most of us do. Most of the clinical trials use CHADS-VASC. It's well validated, and it's pretty simple. Most of us have memorized what the CHADS-VASC is by now. We can calculate that as we see these patients in clinic. But several members in the committee said, wait a second, CHADS-VASC isn't perfect. It doesn't take into account a lot of the other risk factors. What do we do with people like with renal failure? What do we do with people who are in this intermediate risk category? This CHADS-VASC doesn't take into account things like burden and so forth. So ultimately, the vote was that we would recommend that a system be used, such as CHADS-VASC. But if you want to use Atria, Garfield, anything else like that, it would be reasonable to do so. And so we tried to write the guidelines, and there were a few lapses here, but we tried the guidelines in such a way that when we're talking about, say, a CHADS-VASC score of 2, well, in most populations, that translates into about a 2% risk of stroke per year. So whatever that equivalent is in whatever guideline or whatever risk stratification tool you're using, that's what you should refer to. We also talked a lot about the things like has-bled, these bleeding risk factors. And in the community, what's happening is that people are using CHADS-VASC, but then they're using things like has-bled to say, well, this patient is at high risk of bleeding, so we shouldn't anticoagulate them. The problem, of course, is that the more risk factors you have for AFib and higher in stroke, the higher your CHADS-VASC score is, also the higher your has-bled score is. And so ultimately, we thought there was no benefit in using something like these bleeding risk scores as adjunctive to a stroke risk stratification system. That doesn't mean that you shouldn't address the bleeding risk if your patient has a GI bleeding that's recurrent. Well, you address that, but you don't necessarily stop them if they have from anticoagulation if they have a high score on one of these other tools. So what about intermediate risk? And this is where we also sort of discussed these concepts. And we talked a little bit about the introduction of AF burden. There are a few different ways of defining it. But if you have a patient, and we're saying this with a class 2A without a lot of evidence, so limited data here to support this, but if you've got an intermediate risk patient, you can use these other things to help you further risk stratify. And burden is just one of the things. So if you have very high burden patient with a CHADS-VASC score of 0 or 1, you might consider anticoagulating in a patient like that. All right,
can I make a comment about that?
Yeah, please, Mark,
stuff,
jump in.
Marco?
Yeah.
This is an area that I worked on a lot, and one of the issues is that, it's just like in the old days, we had the Framingham risk score for coronary disease, and people are developing better scores, and they're using new markers and everything else, and we're improving the scores. And the idea that we didn't want to enshrine CHADS-VASC as the only way to do it, by making that part of the guideline, we want to keep the door open to let people develop better scores. And maybe now, if we have wearables and other things, we'll have a lot better idea about what people's risks are after we use more modern data. So that's part of the thing. The focus is on the risk rather than the method. So if you get, you have a high risk, that means something different than if you have a low risk. But you can probably improve your risk assessment. So I'll just stop there.
Yeah, thanks, Mark. Yeah, that's a very, very good point. All right, so the choice of a DOAC over warfarin was introduced in the focused update in 2019. Essentially, that remains the recommendation now. It's a class 1 recommendation, unless a patient has something like rheumatic mitral stenosis or a mechanical valve, because all of these DOACs are non-inferior, and some of them might even be superior to warfarin. And the bleeding risk, at least in terms of intracranial bleeding, is better with the DOACs. Maybe not so much with GI bleeding, except for apixaban, but for the most part, overall, the bleeding profile is a little bit better with the DOAC. So there's a class 1 now indication for using the DOAC. That's not new. That was present in 2019 focused update. What is introduced here, though, is this idea that the aspirin, there is no benefit to using aspirin in a low-risk population. So, I very, very commonly see patients with AFib with a CHADS-VASC of 0 or 1 come into my office on aspirin. We know there's more bleeding with aspirin. There doesn't appear to be any benefit. So the advice now is to just take them off of that aspirin unless there's another indication for it. A very common problem too in our field is this idea that, well, I feel like my patient has a higher bleeding risk. Maybe if I underdose them a little bit, maybe cut the dose in half, they'll do better. No randomized trial here, but there's a lot of good retrospective data, nice meta-analyses showing that that's not the case. If you underdose them, if they meet indications and you underdose them, they have a higher risk of stroke. And importantly, they do not have a lower risk of bleeding. So you're really not helping them very much. Now there's a class 3 here, indication here, indicating harm. So you have to be really careful when you're underdosing somebody that you document exactly why and that you understand and the patient understands the risk and so forth. All right, so to illustrate the next concept, I just wanted to present this case. This is a kind of patient we see almost every day in our clinic. So 65-year-old gentleman has myotonic dystrophy and an EF of 35%. So, good candidate for anticoagulation if he develops atrial fibrillation. He had an ICD placed, and 6 months later, sure enough, he has a 4-hour-long episode of atrial fibrillation. Question is, do you anticoagulate them? All right, so asymptomatic, incidentally detected AFib, does that merit anticoagulation? So a lot of debate in this area, but a very common clinical problem. A lot of the data around this question comes from this study called ASSERT. This is an older study, done several years ago, where patients who are in this higher risk profile who had recently implanted pacemakers or ICDs were followed prospectively. And within a sort of a 3-month time period, if they had at least 6 minutes of atrial fibrillation, then they were at higher risk of stroke. So that was one of the first clues that, hey, maybe we should be paying attention to this patient population. The same group did a follow-up study. This time, they followed the patients on average about 2.5 years. And they found, sure enough, you follow them out a little bit longer, you're going to find a lot more patients with AFib. And several patients now are having longer and longer episodes of AFib, many even greater than 24 hours. What they found on long-term follow-up was that if you had AFib for more than 24 hours, were you at higher risk of stroke. But these shorter episodes were not associated. And you think, well, why is that the case? In part, I think that's because with a very short monitoring period, if you have an hour-long episode, that probably means that you have a high burden of AFib. But if you extend the monitoring period to years and years, a 1-hour-long episode during a 3+ year monitoring period means you probably have less burden than that patient who was found to have an hour of AFib, within the first month or two. So it's all about burden. So the greater the burden, the greater the risk. So ultimately, in the guideline, there were a lot of retrospective studies, not just the ASSERT, that suggested this. And so based on all this, we thought that, well, for greater than 24 hours, it was more recommended. So class 2A recommendation, if you have a CHADS-VASC of 2 or more, that you be on anticoagulation. If it was less than 5 minutes, then there's probably no benefit. So that got a class 3. But then there's this gray area. These are 5 minutes to 24 hours. What do we do with that? And ultimately, we decided that if you had a greater risk of stroke, so CHADS-VASC of 3 or greater, and then you had some intermediate length AFib episode, then you may benefit. Again, that decision was based not on randomized trial data. But sure enough, as soon as the guidelines came out, we got 2 potentially helpful randomized trials. So NOAA AFNet was randomizing this patient population with device-detected AFib to edoxaban or placebo, CHADS-VASC score of 2. And essentially that trial was stopped early because there was no clear benefit, and the patient population was having a greater amount of bleeding. So the trial was stopped a little bit early. Almost, just about a month or just a little bit after that, this other study, similar design, but there's some important differences. They used apixaban instead of edoxaban. They had a greater risk in their patient population, so CHADS-VASC score of 3 or more, and then they limited their duration from 6 minutes to 24 hours. So it's that sort of gray area, and I think this was kind of in step with the ultimate guideline, which is that in this intermediate risk group, yes, there is a benefit to stroke reduction here. But there's also a greater risk of bleeding. So you have to balance that out. So ultimately, I think as a clinician, when you see a patient like this, you just have to weigh the risks and the benefits. If they appear to have a very high stroke risk and a reasonable bleeding risk, you might decide to anticoagulate them, and vice versa. So there's still a lot of room here for clinical judgment, and I think it'll be a long time before we know exactly how long for exactly what stroke risk in a randomized trial we need to anticoagulate people. But in the meantime, there's a lot of leeway. Yes.
Has there been any look at the burden versus duration?
Yes. So there is a lot in growing literature on burden, and burden defined in different ways. There's these concepts like density. There's this concept of duration, longest episode, and so on. A lot of good retrospective data, but we just don't have the prospective data to say, okay, after this cutoff of burden, whatever you want to use, there's a benefit to stroke risk. That's what we kind of need, but we don't quite have yet. So what about smartwatch detected AFib? Well, there is an ongoing, and I think they already finished enrolling, and hopefully we'll hear results maybe even this year at HRS on whether or not those at risk for a stroke detected AFib on their smartwatch, randomized to anticoagulation versus not, whether or not they have any benefit. So hopefully we'll get a little bit of clarity there. So we're all pretty excited to hear about that. All right, a few other stroke prevention tools. So if you're looking for alternatives to stroke prevention, there are these left atrial appendage occlusion devices. The way to think about this is there are two different populations. One population that has an irreversible contraindication to anticoagulation, and there is, I think, again, not good prospective randomized trials supporting this, but a lot of good retrospective data and some prospective clinical trials that are not randomized compared to historic data that show that yes, you do have a reduction in stroke. So in these patients who just can't take anticoagulation, a closure device is better than nothing. There is, however, for the other group of patients who may just have a preference, for whatever reason, personal decisions, or maybe they've got a minor bleed or something, where they just prefer not to be on an anticoagulant. There is randomized data showing non-inferiority. First, we saw it for warfarin. Now, more recently, for DOACs, there is non-inferiority to these therapeutics. So compared to the closure devices. So ultimately, we gave this a class 2B recommendation, despite the fact that there's this non-inferiority randomized data. These closure devices do carry some risk, and so remember, when we're thinking about class of recommendation, there's that risk-benefit balance that we make. And so ultimately, this received a class, that group of patients received a class 2B indication. How about sort of opportunistic closure? So if somebody's going for CABG or valve surgery, in the last set of guidelines, there was a 2B recommendation for just doing opportunistic left atrial appendage occlusion surgically. But now we have very nice randomized data. Actually, this Laos 3 data randomized trial that showed a very clear benefit. Now, you have to remember a few things, though. These patients who underwent closure, surgical closure, they remained on anticoagulation. So it's not that you're doing it to get rid of the anticoagulation, but you do it so that you have a further reduction of stroke risk. But everybody remains or should remain on anticoagulation. If you look down there, there's a 2B indication for taking them off of anticoagulation. We just don't have a lot of really good data, and certainly no randomized data to support that. So that gets a class 2B. But there's class 1 indication now. If they're going for surgery, they really should be getting that atrial appendage occluded. I included this in our discussion today because even though there hasn't been a lot of supportive data recently or randomized data, you know, we struggle a lot with thinking about what to do with intracranial hemorrhage and atrial fibrillation. And I think this was an opportunity to just lay out some guidelines that people can refer to when you get that patient, because it's always a challenge. And the summary here is that if they're very high risk of stroke, you know, they've got a mechanical valve or rheumatic mitral stenosis, then you should probably start within 1 or 2 weeks, start the anticoagulation after intracranial hemorrhage. If there's sort of normal risk of stroke, but a low risk of recurrent intracranial hemorrhage, so if they have like a traumatic event or something like that that caused the brain bleed, then it's reasonable to restart their anticoagulation 4 to 8 weeks after their bleeding event. But if they are at high risk of rebleeding in the brain, then you really should be thinking about these atrial appendage occlusion devices. So again, not a ton of data here, but some guidelines for us to use as clinicians. All right, this is another area that I think was helpful. This question of, you know, after PCI, do you in patients who need, you know, aspirin and a P2Y12 inhibitor, do you add that on top of their anticoagulation if they have atrial fibrillation? And then the last set of guidelines, there was some data, but not a lot. So there was a 2A indication for dual antithrombotic therapy over triple. But now there's been a little bit more data, some nice meta-analyses. And so now it's a class 1. So unless your patient is a very high risk for in-stent thrombosis, so if they've had IST before and you're worried that they're going to have another one, then dual antithrombotic therapy is recommended here, and that's a class 1. For our stable patients, you know, 1 year post their PCI or CABG, who need to be or who preferably would normally be on aspirin long term. If they have atrial fibrillation, now the recommendation is take them off the aspirin and just leave them on monotherapy. So just their anticoagulant therapy, and some nice supportive data there. All right, well, we'll check in with Mark here. So this is the AI. What AI thinks Mark is doing or doing that you should not do if you're on an anticoagulation. So I don't know if you did the running of the bulls, Mark, but here the AI thinks you did.
I stayed safely on the balcony, Marco.
All right, very good, very good. All right, so Mark, any burning questions that have come up in the chat?
No, just a comment from Ken about a nice guidance, some videos that he had and mentioned in the chat on how much AF is too much. So there's some back and forth, no major questions, but interesting chat.
Okay.
Doing a great job.
Oh, Sneha has a question. Maybe you can address this one.
Yeah, I was wondering a little bit about what we see often in the hospital, which is post-op AFib, and if there's any differing guidance around duration of that kind of AFib. Cardiac surgery, which is not cardiac.
Yeah, Mark, did you hear that? So the question was, what do we do with post-op AFib? Does burden play a role there? Do you remember what we did in the guidelines?
No, I don't remember exactly how we treated that. Yeah. It's been a while. Sorry.
Yeah. So burden really wasn't addressed in the post-op period, but we did address it in the sense that if you do see it, not burden, but if it is present, then you should just think about monitoring more because those patients are at higher risk. Again, not based on randomized data or anything like that, but burden, you're right though. I mean, I think burden should play a bigger role in these kinds of questions, but it's just not something that we have enough data to make a recommendation around.
I think there was a question from Dr. Francois Haddad about is there a role of evaluating left atrial size for stroke prevention in any of the stroke prevention scores?
Yeah, so yes, there are some scores that do take into account left atrial size, but again, that I think, yeah, there are a couple. There are a few scores that do, and we do address them in the guideline, and also in that sort of idea of that intermediate risk patient, where you're thinking of things to add to help you further stratify. So burden was one of them, but left atrial size is another one. And any addition there, Mark? Anything else about left atrial size?
No, I do think that's, another example of additional information. It's sort of in that additional information category to help you do the stratification if you know that. But I think that it's when you're on the fence.
Yeah. Yes.
What, Marco, do you comment on how you approach in terms of cardiomyopathy? HCM is specifically written into the guidelines, which makes sense. But my understanding, maybe it's updated, that basically all other forms of cardiomyopathy are not included.
Right. Yeah. It's not. Yeah. I mean, I think in part because there's just so much good data on stroke risk in patients with HCM, and it's very, very clear that their stroke risk is just through the roof if they have AFib and HCM. I think you're right that there are these other cardiomyopathies where we are going to see this much higher stroke risk. We just don't have the data to support that. And the guidelines make specific comments around HCM and how you shouldn't use the CHADS-VASC or these other forms of risk stratification, but we didn't address these other cardiomyopathies. Like,
how do you approach, say, for example, early onset AFib, where oftentimes the patients have the lowest CHADS-VASC score? However, they're also enriched for cardiomyopathy.
Yeah. So we do, and I'll get to this a little bit more at the end, but we do pretty extensive evaluation in those with early onset AFib, including genetic testing and imaging. We MRI all of our early onset AFib is specifically looking for these kinds of structural abnormalities. But I do not anticoagulate them unless they have manifest myopathy. Yeah.
Yes. One more question in the chat on anticoagulation questions from Dr. Alex Steverson. Is there guidance on anticoagulation after successful ablation with no AFib on monitoring?
Yeah, Mark, do you want to take this one? So the idea of anticoagulation after AFib ablation.
I don't. I think the idea of the risk is so low that you don't have to do it is hard. I think people were shying away from saying that. It had to be, you have to wait a while to make sure it really worked, especially given any risk of recurrence later. So, I don't think it was anything immediate for ablation.
Yeah, and I'll just add that there are ongoing studies to address this question, but in the guideline, I think we ultimately said that there's not enough data to support taking them off. Yeah. Yes, Dr. Marion.
Still regarding anticoagulation.
Yes.
Any comments or discussion among the writing group about PRN? Anticoagulation. I don't know if that's something you're going to have to address.
So not in the guideline, but we have now this REACT study just looking at sort of pill-in-the-pocket PRN use of anticoagulation. So we have a large, we just started just a few months ago this large study called REACT AFib, where we're taking people who have low burden AFib and are already on a DOAC, and randomizing them to using the smartwatch for pill-in-the-pocket approach of anticoagulation versus control. So maybe in the next set of guidelines, we'll have the results of that, but it's going to be a few years. But that is a plug for that study. So if any of you have a low burden AFib patient with a CHADS-VASC a 4 or below, then let us know, because they may be candidates for this study, and we will give them watches if they're randomized to intervention. Yeah. Yes, AJ.
For your case, what was the final?
No, we couldn't. I mean, the guidelines had been, yeah, but but yeah, I mean, for that particular case, when we ended up anticoagulating even before that happened, even before the guideline discussions. But yes, we ended up anticoagulating that patient. I sort of value or factor in myopathy a little bit more than some of the other risk factors. He had an EF of 35%. I thought he was at high enough risk, and I knew that he would likely have progression of AFib. Mm-hmm. Yeah, that's a good. And I've thought about that. I think the guidelines kind of reflect ultimately what was found in those studies. So I probably would not have changed the guideline. Yeah, based on that, it could have gone differently though, depending on the findings. Yeah. Yes, Jack. Yes, that is another argument. So in the NOAA trial, there was a much bigger bleeding risk. In the Apixaban study, the control was aspirin. So there was a greater bleeding risk, but you can imagine if those patients had been randomized to placebo, that bleeding risk might have been even bigger. So you're right. I mean, there's no question here. I think that it's not very clear yet, but that again leaves a lot of room for clinical judgment. Dr. Mary, yeah.
We see a lot of patients with coronary disease, and you mentioned that there's a class 1 indication to use anticoagulation along with antiplatelet therapy.
Yes.
Based on any clinical trial evidence?
Yes, so let me bring that up. Yeah, so the FIRE trial, so they randomized patients rivaroxaban versus Riva plus aspirin, and they had it was a non-inferiority study, but so rivaroxaban alone was non-inferior, and there was lower bleeding risk. So it's based really. I mean, the class 1 comes essentially from this study.
And it generalizes to any DOAC.
We think so. Yes. I mean, Riva was studied here, but we think so. Yeah. Okay, let's go on to rhythm control. All right. So I think a lot of us trained with Affirm, with the thought that, hey, if your patient's not that symptomatic, rate control is probably just as fine as rhythm control. There, a few retrospective studies that kind of challenged that question, especially, as rhythm control itself evolved, in particular with the really rise of the use of ablation. And this study was very influential, this East AF Net4 study. It was a very large study that randomized patients to rhythm control, primarily with the intent that, this was done in Europe. So the intent was going to be that, these patients would mostly be on antiarrhythmic medications versus usual care. And that's what happened when they randomized patients to rhythm control. Most of them got medications, so antiarrhythmic drugs for rhythm control. Eventually, though, over time, up to about 20% of patients in that arm ended up getting an ablation done. So just keep that in mind. Also, this was a higher risk group, so also keep that in mind. But the idea here was that, well, maybe if we get to them early, within the first year of their diagnosis, that rhythm control might be better than usual care, and that ended up being the case. So this trial was actually stopped early as well, but this time for efficacy. So there was good evidence that early rhythm control in this patient population was beneficial. So why is this different from Affirm and so on? A big part of this is probably because the idea here was to act early. So if you get to these patients early before they remodel and so forth, you might get better benefit. But also, again, we're entering this ablation era. 20% of these patients were getting ablated, so maybe there's something to that. And now, even if your patient doesn't fall into this category of early detection, there's still this concept that, well, maybe rhythm control is better anyway than rate control, even in asymptomatic patients. And so, based on retrospective data, we know that with rhythm control, you get less dementia, a less likelihood of progression to persistent and longstanding persistent AFib. So you have something to point to if you really want to rhythm control your patients. You have that discussion with them and say, hey, if you're worried about developing dementia and so forth, then rhythm control might make sense, and even in those asymptomatic patients who've had AFib for more than a year. So there is some leeway here as well. The question that has come up in our field, and this is sort of one of the burning questions, is whether or not, if you choose rhythm control, whether or not ablation as first-line therapy is better. And there were several randomized studies that showed that yes, if you do an ablation early as a first line, you get less AFib. You get less burden of AFib, less progression to persistent AFib. So that's pretty clear. So if you've got a symptomatic patient and you're thinking about rhythm control, then you can tell them that yes, if you do an ablation first line, chances are greater that you'll have success than just medications. But what about hard endpoints? So things like mortality. And Cabana was really designed to address this. This would have been, I think, groundbreaking if they had shown in the general population that if you do an ablation as first line therapy, that you get a mortality reduction, then I think we'd be in a slightly different world. But what they found was that the primary endpoint, which was death, stroke, major bleed, cardiac arrest, so they were kind of going for these really hard endpoints. They did not see an improvement in first-line therapy with ablation versus medical care. Now, you ask 20 different EPs their interpretation of the study, you get 20 different answers. Many of the EPs will point to, well, what about the on-treatment analyses? Those who actually got an ablation did better, but obviously there are a lot of flaws to that kind of thinking. In theory, maybe there is something there, but the study wasn't designed to show that. So at least what we can say is, in Cabana, there was less AFib. There were fewer AFib hospitalizations. Those were all secondary endpoints. It's consistent with all the other randomized trials, but not a mortality benefit. So there is a class 1 indication now. If you've got a younger patient with a few comorbidities, then first line therapy is useful. And notice the wording there is useful. We didn't say should be done, but is useful. So that's a class 1 with the based on the data that we talked about. In the slightly older patients, maybe with more comorbidities, there's still a class 2A indication here, and we said first line with ablation can be useful. So look at the wording and use your clinical judgment, but you've got some leeway there as well. Now, this is very different for heart failure patients. So I have to say, I think this study, I think, surprised most of us in the field. When this study first came out, taking patients with heart failure and randomizing them to ablation as first line versus medical therapy. Because in the older guidelines, it was all about rate control. We didn't even think that rhythm control was that important in heart failure patients, and all the guidelines were all about how to rate control these patients. But this study kind of changed our mentality. We used to avoid bringing these patients to cath lab because they had, we gave them a lot of fluids in the lab, and they always had heart failure afterwards, and so we didn't like doing it. But now we see that there is mortality benefit, and that wasn't in just CASTLE-AFib, but a few other randomized studies and meta-analyses showed a clear benefit. And so now there's a class 1 indication for using ablation as a first line approach in this population. All right, so when I think about Mark learning about rhythm control, this is, well, when the AI thinks about it, this is what it sees. So any good flamenco shows in Spain, Mark, that you've been to?
Oh yeah, got to go to flamenco. The hard thing is going out to dinner at 10 o'clock.
But that's okay if you take your siesta, right?
There you go. Exactly, a good tradition.
Okay, so we're getting here to the home stretch. I just wanted to point this out because we see a lot of these patients with early onset atrial fibrillation. So we know that there are many inherited cardiomyopathies related to atrial fibrillation. In the older guidelines, the recommendation was, well, unless there's a very strong family history, we shouldn't be doing genetic testing on these patients. And we and others have looked at these early onset atrial fibrillation patients and are finding that many of them do have pathogenic or likely pathogenic variants associated with their early onset atrial fibrillation. And now in the guidelines, what we say is if they're below the age of 45, please send them over for genetic testing and counseling. The other thing that we added here in the guidelines was that if they're really, really young, less than 30 years old, then we should also be doing EP studies, because it turns out a lot of them have AV-NRT or AVRT as the reason for their atrial fibrillation, and that AFib goes away when you ablate them appropriately. So that's another new. There's a lot more in the guidelines. We don't have time to go through everything. A lot of special populations. This is a plug for our inherited clinic. So if you've got an early onset AFib below the age of 45, send them our way. We'll do genetic testing, counseling. We usually do cardiac MRI as well. All right, so that will close